This is our second podcast related to peripheral blood, and in this podcast we're going to talk about white blood cells and platelets. And then when we conclude this podcast, we'll show you just some examples of peripheral blood. Now, the white blood cells are leukocytes. As we've suggested already, they're carried by the blood, but they function mainly in connective tissue. With the exception of lymphocytes, white blood cells don't have that long of a lifespan. We can classify the white blood cells very broadly into granulocytes and agranulocytes. So the granulocytes would be neutrophils, eosinophils, and basophils, and the agranulocytes would be lymphocytes and monocytes. We do want you to understand something about the cell size and differential count for the white cells. This is important in your training, and it's something you're going to need to start knowing from right now, basically. Neutrophils are about 60% of a differential count. Eosinophils are about 3%. Basophils are relatively rare, less than 1%. Lymphocytes, 33% in a differential count, and monocytes about 5% in a differential count. We're going to expect you to know those numbers. I'm not so concerned that you know the exact sizes of the white cells. Something to keep in mind, the monocytes are the largest cells in peripheral blood, and again, you don't have to necessarily remember the dimensions, but that might help you to recognize a monocyte, that you'll recognize it as the largest cell in peripheral blood. Now, as we said, the lifespans for white cells are not that long, so neutrophils only live 1 to 2 days, eosinophils maybe a week or two, basophils only 1 to 2 days, monocytes live for a few days up to a few months, but of course lymphocytes can live for many years, especially the T and B memory cells. We'll start our discussion with neutrophils. Neutrophils are also called PMNs, polymorphonuclear leukocytes. A characteristic, the neutrophils have multiple lobes of the nucleus, usually 3 to 5 lobes. The number of lobes in the neutrophils increases as the cells age. Neutrophils have lysosomal granules that contain acid phosphatase, elastase, peroxidase, various defensins. These granules are released in diseased conditions and when tissues get damaged. The lysosomal granules are called non-specific granules. We contrast those non-specific granules with the specific granules in neutrophils that contain substances like collagenases, phospholipases, complement activators, or lysozyme. The granules here are antibacterial, and the specific granules are neutral color granule, and you can see some of these granules. They're a clear or neutral color, hence the name neutrophil, for the specific granule being a neutral color. Neutrophils function to fight bacterial infections, and they're about 55 to 60% of the total white blood cell count. Neutrophils function within interstitial spaces, and this cartoon shows how neutrophils function in connective tissue. And how do they get there? Circulating neutrophils are slowed by interaction of their surface adhesion molecules, selectins, with specific receptors on endothelial cells. So the neutrophil selectins interact with selectin receptors on the endothelial cell surface. The neutrophils will roll along on the endothelial cell surface, and they'll adhere in response to various chemokines that are secreted by the endothelial cells. The chemokine secretion will induce expression of other adhesion molecules like integrins and various other cell adhesion molecules on the neutrophil and endothelial cell surfaces. The neutrophils will bind tightly to adhesion receptors on the endothelial cells, and they'll extend pseudopodes into intracellular junctions that have been relaxed by histamines and heparins, which are secreted from mast cells cells in connective tissue, and the neutrophils will diapedese across the vessel into the interstitial spaces. All white blood cells utilize similar strategies to get into the connective tissue spaces where they function. Neutrophils are phagocytic cells at the site of inflammation, and this cartoon is just showing phagocytosis for neutrophils, but the same process can be used to describe phagocytosis for monocytes or antigen-presenting cells. So here's a neutrophil recognizing a bacterial cell. Antibodies are put on the surface of the bacteria, and then there are receptors on the neutrophil surface that recognize these antibodies that are bound onto the bacteria. The neutrophil puts out some pseudopose, surrounds this bacteria, ingests it into a phagosome, and then you know the rest of the story. The phagolysosome forms, the bacteria is digested. If we look at eosinophils, nucleus with maybe 2 lobes, sometimes 3 lobes. They have very bright brick red granules. You can see these very large, bright brick red granules. Eosinophils are about 3% of the total white blood cell count. These specific granules that we just mentioned, these bright brick red granules, they stain bright red with right stain. They contain substances like major basic protein, eosinophil cationic protein, eosinophil peroxidase, eosinophil-derived neurotoxins, and histaminase. The function of eosinophils, they dampen degranulation of mast cells and basophils. Eosinophils are antiparasitic and anti-allergic. So if you have parasitic infections, you'll see an increased eosinophil count. If you have a lot of allergies, you'll see an increased eosinophil count. Basophils resemble a mast cell. Basophils perhaps less than 1% of the total white blood cells in a differential count. The nucleus in basophils is incompletely lobed. The granules in basophils are similar to mast cell granules in that they contain heparin, histamine, heparan sulfate, and various leukotrienes. These granules, when they're released, cause vasodilation, which can be associated with hypersensitivity and anaphylaxis. The granules stain a very intense dark blue, and they're very large granules, and they're so dark and they stain so intensely that they generally obscure the nucleus, and you can use that feature to help you identify basophils in peripheral blood. Basophils have IgE receptors on their surface. Basophils are short-lived, and some authors think that basophils and mast cells share a common stem cell in the bone marrow, and some people even suggest that basophil is just a mast cell that's in peripheral blood. Lymphocytes have a fairly large nucleus that fills most of the cytoplasm, so you can see a very large nuclear to cytoplasmic ratio. Lymphocytes are smaller than granulocytes, and they lack large specific granules, so they're termed agranulocytes. T lymphocytes act against virally infected cells and tumor cells. We've already talked about T lymphocytes and B lymphocytes in an earlier podcast. B lymphocytes produce antibodies, and as you know, B lymphocytes mature into plasma cells. As we just said, these cells are called agranulocytes because they don't have the very large granules, the eosinophilic or basophilic or neutral granules that you'd see in eosinophils, basophils, or neutrophils, respectively. Lymphocytes make up about 25 to 33% of the total white blood cells in a differential count. Most of the lymphocytes that are in peripheral blood are circulating T lymphocytes that are involved in immunologic surveillance. And while you can readily recognize lymphocytes in peripheral blood smears, you will not be able to tell the difference between T and B lymphocytes on such smears. You should remember lymphocytes structure the body's adaptive immune response. Monocytes. Monocytes are large mononuclear phagocytes of peripheral blood. They're also granulocytes. They're the largest cell in peripheral blood. Monocytes can give rise to tissue macrophages. The cytoplasm in monocytes is abundant, and it's a blue-gray stain with many fine azurophilic granules, so it gives the cytoplasm a ground glass or foamy appearance. Now, notice I said that a monocyte is considered an agranulocyte, but I just said they have many fine azurophilic granules. A little bit confusing. The granules are very small lysosomal type granules. They're non-specific granules, so you got to be a little bit careful here. Monocytes have abundant lysosomes, which are equivalent to the non-specific granules of the neutrophils, basophils, or eosinophils, but they're much smaller, and that's what gives the monocytes their ground glass appearance in the cytoplasm. Monocytes may have vacuoles present in the cytoplasm. You can see some of the vacuoles here, and they'll have a characteristically indented nucleus. Monocytes make up about 5 to 8% of the total white blood cells in a differential count. If one looks at changes in leukocyte count, leukocyte numbers can increase or decrease. So, for example, you may see increased neutrophils under stress conditions with an acute bacterial infection, or maybe with a myelocytic leukemia. If the neutrophil count gets really high, you'd have, for example, a myelocytic leukemia. Neutrophil counts may decrease with aplastic marrow, maybe will decrease because of poisons, or with some nutritional deficiency, or other drugs may cause neutrophil counts to go down. Lymphocytes might increase with chronic bacterial infections, with viral infections, with infectious mononucleosis, for example, or with lymphocytic leukemias. On the other hand, certain conditions will cause lymphocytes to decrease. Various drugs can cause a decrease in lymphocytes. HIV, remember HIV, the virus attacks T helper cells, so that'll cause a decrease in lymphocyte number. Eosinophils will be increased in allergic reactions or with parasitic infections. Taking various types of adrenal steroids might cause a decrease in eosinophil count. Now finally, platelets. Platelets are pieces of megakaryocytes, and this is an example of a megakaryocyte in the bone marrow. The platelets break off of the megakaryocytes in the bone marrow and get into the peripheral blood. So here the little tiny dots here would be the platelets. Platelets, as we said, are pieces of megakaryocytes, and a megakaryocyte, we'll talk about these when we talk about bone marrow, they're a big polyploid cell in the bone marrow. Platelets are a biconvex disc. As we said, they're relatively small. Lifespan of platelets, about 10 days. Platelets function in clot formation at a site of injury. Platelets help to maintain endothelial integrity. Platelets secrete platelet-derived growth factor, which is chemotactic for inflammatory cells. Platelet-derived growth factor is also mitogenic for fibroblast and smooth muscle cells. This just shows the structure of platelets. Very characteristic ring of microtubules around the periphery of platelets. Platelets also contain actin and myosin, and they contain these various granules. So the alpha granules are the most numerous. These granules contain fibrinogen, various coagulation factors, plasminogen, platelet-derived growth factor, and then there are some minor granules like lambda granules and delta granules. Platelets have an open canonicular system through them, so the granules are not released by exocytosis. Rather, the granules just release their contents into this open canonicular system, and the granule contents just leach out of the platelets into the serum. This diagram and the next few highlight how platelets respond to vessel injury. As you know, an injury to a blood vessel will expose collagen in the underlying connective tissue, and so the platelets will get attracted to that collagen. Platelets have a high affinity for collagen, so they'll bind onto that site of injury. They will then be activated by integrins in their membranes, and then a variety of substances released from the platelets and endothelial cells cause a cascade of interactions. So, for example, thromboplastin will convert prothrombin to thrombin. That will cause the platelets to release thrombospondin. Thrombospondin plus ADP will increase platelet aggregation. Thrombin will convert fibrinogen to fibrin, which will bind platelets onto the vessel wall. Factor IV will cause blood coagulation. Von Willebrand factor will cause platelets to adhere to the vessel wall. As these platelets adhere, this clot will contain platelets, fibrin, and the cells will enlarge and contract because of the actin and myosin in the platelets. And then in response to platelet-derived growth factor, fibroblasts and smooth muscle cells will move into the site of injury and undergo mitosis. Eventually, the endothelial cells will undergo mitosis, and they'll cover the break in the endothelium. So now this table is just here to summarize what you want to consolidate in your study of peripheral blood. So we can look at numbers of cells, number of erythrocytes. Males have a little bit higher number of erythrocytes than females. Lifespan of the red cells 120 days. Remember that reticulocytes, about 1% of the circulating red blood cells count. 1% of them would be reticulocytes, and reticulocytes take 3 days to mature into erythrocytes. Neutrophils about 5,000 per cubic microliter, eosinophils about 150 per cubic microliter, basophils much rarer, lymphocytes about 2,400, monocytes about 350 per cubic microliter of blood, and then platelets about 300,000. Look at the differential count. You need to know the percentages in a differential count. You want to know about the lifespan as you consolidate your study. You can look at various situations where numbers would change. So for example, neutrophil count about 5,000, but they'll increase dramatically in an acute bacterial infection. They'll increase way above 40,000 maybe in a chronic myelogenous leukemia. They may decrease with a chronic infection. So I'd like you to take some time and go over this table to look at different things that would affect cell numbers in the various white cells. You want to spend some time looking at the specific and non-specific granule content in the white cells, because this helps to define function. Let me take the last few minutes in highlighting some of the cells you'll see in peripheral blood. So here we see a lymphocyte and 2 neutrophils in peripheral blood. And neutrophils here, polymorphonuclear leukocytes. Here's another example of a neutrophil with a little appendage here right at the tip of my pointer called the drumstick. That appendage contains an inactive X chromosome. So we can say this neutrophil most likely came from a female donor, a donor that was XX. And remember, one of the X chromosomes is inactive. The drumstick represents that inactive X chromosome. Here are some neutrophils and an eosinophil in peripheral blood, and notice the distinct bilobed nature to the nucleus in the eosinophils contrasted to the multiple lobes here, 1, 2, 3, 4 lobes in this neutrophil. Back to the eosinophil, look at the distinct orange granules, almost the same color as the red blood cells in a typically nice stained peripheral blood. The eosinophil granules are pretty much the same color as the color of erythrocytes. Here are some platelets in the peripheral blood. Here, some large lymphocytes in peripheral blood. Here, all examples of lymphocytes. Another lymphocyte here, and platelets. This is a nice example because you can see the Golgi halo particularly clearly on this lymphocyte. Very characteristic of lymphocytes, a very high nuclear to cytoplasmic ratio. In the lymphocyte, the nucleus takes up the majority of the volume of the cell. Here's a plasma cell in peripheral blood. This is unusual, and it would be difficult for you to identify it in peripheral blood. I have this slide in to show you the distinct Golgi halo in this plasma cell. Here's a megakaryocyte in bone marrow, very huge. An example of one here and two more here. Very large polyploid cell, multi-lobed nucleus, and in the bone marrow, pieces of this cell break off to form the platelets. Here's an eosinophil in peripheral blood. Again, the bright brick red granules, the bilobed nucleus. The electron micrograph shows the bilobed nucleus, and the eosinophilic granules have this characteristic crystalloid structure. So you may see an electron micrograph on a shelf exam, and they may expect you to be able to recognize this as an eosinophil, and you'd recognize it because of two features: the nucleus, which looks bilobed, and this very characteristic crystalloid structure. Here's a neutrophil in peripheral blood, and here's a basophil. Notice the dark blue staining granules in the basophil almost obscuring the nucleus. And then some examples of platelets in the peripheral blood. Peripheral blood monocytes, very large cell. Look at the indented nucleus in this example here and in this example here. Look how large the cells are, especially in relation to the diameter of a red cell. Look at the indented nucleus, the lobulated nucleus, and you can get an example of vacuoles in the cytoplasm of the monocyte. The monocyte has a very mottled or foamy looking cytoplasm. Peripheral blood, a large lymphocyte on the left and a monocyte on the right. Look at the monocyte is larger than the lymphocyte. Although it's larger, compare the nuclear cytoplasmic ratio to the lymphocyte and the monocyte. The lymphocyte has a larger nuclear to cytoplasmic ratio than the monocyte, although the monocyte is a larger cell than the lymphocyte. So two features to keep in mind: the monocyte, the largest cell in peripheral blood, an indented nucleus, a foamy cytoplasm, compared to the lymphocyte. The lymphocyte has a larger nucleocytoplasmic ratio, and in fact has the largest nucleocytoplasmic ratio of all the white cells. Here are red blood cells from a sickle cell patient. You can see the sickle cells here, the sickle cells here. The deformed cells don't readily move through the small capillaries because the spectrin cytoskeleton gets altered. So in sickle cell anemia, the red cells lose their flexibility, and so they get clogged up in capillaries. The electron micrograph, the scanning micrograph showing the sickled shape.